Well, welcome to Jerry Pal Podcast number 3. Alex, do you want to start us with a song? I was thinking in honor of Bob Dylan's receipt of the Nobel Prize in literature. How about some musical literature, Alex?
I don't think I have any Dylan on hand. But what I do have is Keep Your Hands to Yourself by the Georgia Satellites. We'll do Dylan next time. I got a little change in my pocket going jing-a-ling-a-lang. Wants to call you on a telephone, baby, and give you a ring. But each time we talk, I get the same old thing. Always no huggy, no kissing until I get a wedding ring. My honey, my baby, won't you put my love upon no shelf? She said, don't hand me no lines and keep your hands to yourself.
We thought it would be good to talk about a new article that just came out in JAMA IM, I think a week ago. The Association of Increasing Use of Mechanical Ventilation Among Nursing Home Residents with Advanced Dementia and ICU Beds.
Oh, that's a mouthful. So I was really struck by one finding in this study, and I wonder what you two think of this, is that from 2000 to 2013, the chance that a patient with advanced dementia will get mechanical ventilation doubled. And presumably the illnesses haven't changed over this time. So that for some reason we're using this procedure, this highly invasive procedure, twice as often in people with advanced dementia. And not only that, it varies wildly depending on what hospital a patient goes to. So it's not necessarily based on how sick they are. There was some feature of the hospitals that seemed to be dictating whether they got this procedure.
Yeah, and it did seem that a big feature of that was just the number of ICU beds the hospital had or added.
Right. If you build it, they will come. Which raises a question for me. This study focused on patients with advanced dementia. Are ICUs also admitting more patients with heart failure, more patients with X, Y, and Z serious condition as well? We can't answer that with these data. But if you build it, they will come sort of issue is well known within critical care. The more ICU beds the hospital has, the more they're filled with patients with serious illness, including those with advanced dementia. So I think that's one of the factors, but it doesn't explain what you were talking about, which is that there seemed to be differential use of the ICU for people with advanced dementia based on hospital care. And there's something more there about the norms and culture of those individual hospitals that they couldn't penetrate with this large data set sort of study, but probably has to do with, whether they introduce goals of care discussions early in the course of illness for patients with advanced dementia versus late versus never. Right?
Yeah. But one would hope, regardless of how you feel, how often this procedure should be used, one would hope the decision about whether a patient with advanced dementia is subjected to mechanical ventilation is based solely on patient benefit, that you think they'll be better with it. And it appears that, a huge part, this paper seems to show that a huge part of what's driving the decision is if you show up at a hospital that has a lot of ICU beds, you end up in an ICU, and then what do you do when you're in the ICU? You go on the ventilator. Mm-hmm. So that that doesn't seem to be a good reason to be doing this procedure on patients.
Yeah, and I guess that was the surprising thing for me. My assumption up to this point was if you had a pneumonia or in a nursing home, you could potentially treat that pneumonia in a nursing home, and prognosis may look very similar between those who get admitted to the hospital and those who don't, versus to the point where we're thinking about mechanical ventilation. My thought was, they're in respiratory distress. They either need it or they don't. One will improve survival, mechanical ventilation, because the other person is going to die without it. I think this study begins to question that, because there has been a doubling in the use of mechanical ventilation, but also there was no improvement in 1-year mortality.
Well, that was striking, Eric. So, they did this really interesting analysis. So they looked at the hospitals that were in the top 10% of using this procedure. And then they looked into hospitals that were the least likely to use it, the bottom 10%. So you would think, okay, well maybe, there's a cost here. It's an uncomfortable procedure, it's scary, but maybe some patients gain a longer life because of this. But that's not what happened. There was absolutely no difference in survival between hospitals that use this a lot and use it a little. So this seems to be doing nothing for patients, this increased use of mechanical ventilation. It seems like, is this all harm and no benefit?
I don't know how to. It depends on what the outcomes are when you're assessing harms and benefits. There may be. You could conceive that there are some patients who do survive the mechanical ventilation, the ICU stay, who have benefited from being in the ICU. But this isn't a randomized control study. We can't know that for sure. But my concern is, so I don't allow that there are some patients who benefit. But I would say that the harms and the risks to patients are serious, and that we have alternatives that are likely much more comfortable for patients who have advanced dementia and for whom an ICU stay is debilitating, frightening, and often leads to death in any case.
Yeah, I think one has to be careful about, when you have like a large epidemiologic study like this, one can't always go down to an individual patient and say, based on what this big study says, we know what's right for every individual, because when we practice medicine, we have to base it on evidence, but then we have to modify that evidence by the person right in front of us. And sometimes there's very good reasons why, the evidence doesn't apply. If, sometimes when patients are put on mechanical ventilation in this situation, there may really be a belief that the patient's going to benefit, but it may actually be the case that they're not benefiting at all, or maybe they're even being harmed. That, putting them on just simple oxygen without the ventilation, treating them with antibiotics and supporting them, maybe there's just as much of a chance of survival as with mechanical ventilation, but without all the horrible suffering that goes along with it.
Mm-hmm.
I can clearly remember multiple patients that I've worked with whose goals are very much focused on survival. That even in a state of being bedbound in a nursing home, that they still would want life-sustaining interventions such as mechanical ventilation or anything else, including dialysis, that they've stated in their past preferences when they've talked to individuals like family members, and they may have even written an advance directive. So for those individuals, how should we think about mechanical ventilation for them?
I find that a really hard question, Eric, and I'd be interested in how, the two of you discuss this issue when you're attending on palliative medicine. I think the way I've come to think about it is we need to really honor patients and families who, length of life is really important to them and they want to do all they can to live as long as possible. But we also have to be honest about the limits of medical interventions, so that it's sometimes believed that these interventions that are potentially life-prolonging are life-prolonging in all instances, so that it in fact is the case that sometimes dialysis, for example, is not life-prolonging, and sometimes mechanical ventilation is not life-prolonging, that sometimes medicine has its limits, and that sometimes our ability to prolong life is very limited. And there's probably, advanced dementia is probably a situation that really epitomizes that, is that this study really calls into question whether this procedure even is achieving its goal.
So maybe akin to kind of the early studies looking at feeding tubes, where I think the underlying thought before those early studies were, of course, feeding tubes prolong survival. How could they not prolong survival? You're adding nutrition to this individual. It must increase survival. Yet everything that has come out shows that it doesn't, not because, likely because they're dealing with the disease that they're dying from, rather than they're just not getting enough nutrition.
I think that's a really good point with respect to advanced dementia, is that when patients get these complications, we think of it as the complication that's hurting them. The complications are signs of how bad their dementia is and how much it's progressed. And treating the complication does not treat the underlying dementia, and that the treatment of advanced dementia is primarily palliative. I mean, the medically invasive things often will do more harm than good. I think there's a bias in medicine that I think is really common, is that when a procedure's been done and a patient does okay after the procedure, there's an assumption that the procedure helps, so that you're put on a ventilator and you're alive. Therefore, the ventilation saved your life. This study suggests that's probably, in fact, not happening. We don't know what would have happened to that one person if we didn't put them on a ventilator. But it's generally possible, and this study suggests that it's likely that if the patient wasn't put on the ventilator, that they would have survived as well, but they would have survived without that trauma.
So my last question is, so what do we do with this data? How can we improve the lives of individuals with advanced dementia living in nursing homes, when it seems like we've developed a healthcare system that is really good at achieving its results that it's getting, which is, and this comes from other data from Joan Tino, is that the system is very good at churning through patients, getting them transition between multiple settings in the last 6 months, month of life, and really focusing on hospice care maybe just in the last 3 days of life.
Well, I think there are several answers to that. One is that we need to understand the problem better. So if we had more research understanding what's actually going on in the nursing home, and some of that is more qualitative, asking the, why is this going on sort of questions that are hard to answer with a secondary data set study like this. But we already know that there's some low-hanging fruit here. The primary approach to caring for patients with advanced dementia in nursing homes should be palliative, 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 palliative. And that's just not the case. And some of that has to do with cultural issues, some of it has to do with the way reimbursement and financial incentives for nursing homes. But we need to do a better job of incorporating a culture of palliative care in nursing homes in the United States. And that's, I think, the first place to start, and we don't need more evidence before we start doing that.
The need is definitely there. 1 out of 4 residents will die in a nursing home. Yet, for palliative care is now in over 90% of hospitals with more than 300 beds. Palliative care is being integrated into clinics and cancer centers. Palliative care programs are being developed for home-based palliative care. Yeah, there is a dearth of palliative care outside of hospice in nursing homes. The field of palliative care has to think of models where we can actually deliver palliative care in these settings. It just reminds me of a recent article that came out in JAGS that we wrote about in GeriPal just a week ago. So the study looked at data from 2 palliative care provider organizations that were subsidiaries of hospice agencies. And they identified those patients who got palliative care consultations in North Carolina and Rhode Island. And what they found was those individuals who got palliative care consultations had reduced hospitalizations in the last 7 days of life, last 30 days of life, last 60 days of life, reduced ED visits in the last 30 and 60 days of life, and fewer burdensome transitions, including going to the hospital in the ICU. So I think the important part of this is, as palliative care providers and organizations, we have to start also thinking about the nursing home as an important place where palliative care needs to take place, not just primary palliative care by nursing home providers, but giving specialty level palliative care to these individuals as well when they need it.
Well, this was a provocative study. It's impressive how the Joan Tino and her group just keeps adding to her knowledge of how to better care for patients with dementia.
And if you want the link to the article, it'll be on the GeriPal website, as well as other articles that we cited during this podcast. Alex, can you give us one more verse?
Baby, 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 why you want to treat me this way? I'm still your lover boy. I still feel the same way. So when she told me a story about free milk and a cow, and said no huggy, no kissing until I get a wetting bow. Said my honey, my baby, don't put my love upon no shelf. She said don't hand me no lines and keep your hands to yourself.